I am so excited and honored to have my next guest here today. Her name is Dr. Banafsheh Kashani. She is double board certified in both obstetrics and gynecology, as well as reproductive endocrinology and infertility. She's been treating infertility patients in Orange County for over a decade. She graduated cum laude and Phi Beta Kappa from University of California, Irvine, and Dr. Kashani received her medical degree from the University of South Alabama College of Medicine, where she graduated top of her class. She completed her residency training in obstetrics and gynecology at the University of Southern California, where she received tremendous experience in all facets of obstetrics and gynecology. During this training, she had a specific interest in reproductive endocrinology and infertility, which led her to pursue a subspecialty in reproductive endocrinology and infertility at Rutgers, New Jersey Medical School. After her fellowship, Dr. Kashani practiced at Kaiser Permanente in Orange County, followed by Eden Centers for Advanced Fertility in Newport Beach. Since Dr. Kashani is focused on providing her patients with the most personalized approach to fertility services and treatments, she opened up her own practice in 2020, and her practice mission is to ensure patients feel comfortable and cared for, since fertility treatments can be overwhelming at times. Dr. Kashani has received numerous awards. She was awarded the ACOG Gibbons Medical Student Award, and while in residency training at USC, she was recognized as Resident of the Year. She also was elected to be the Administrative Chief Resident at LA County USC Medical Center. And while in fellowship at Rutgers, New Jersey Medical School, she was recognized for her teaching and mentorship of resident physicians and medical students. Dr. Kashani has also conducted extensive research in female reproduction with specific focus on the endometrium and implantation. She has written papers reviewing the medical management of fibroids and the effects of fibroids on fertility. Additionally, Dr. Kashani has authored papers in the areas of fertility preservation and fertility in women with PCOS and Turner syndrome. I am so excited, thrilled, and honored to introduce my next guest, Dr. Banafsheh Kashani. Dr. Kashani, I would love to hear more about your practice and what led you to be a specialist in women's health and infertility. I've had the privilege of working with you for, gosh, probably over 5 years now, and there's just so much more that I'd love to learn about you. Every time that I hear you lecture, I learn so much from you. So I'm excited to have you on my podcast to be able to share some of your wisdom and knowledge with everybody, with our community. So I'd love to hear more about your practice and your practice passion.
For sure. Well, thank you, Dr. Yang. It's actually a pleasure to work with you. And I've learned a lot from you as well. And the patients obviously love you. And it's just so nice to be able to have this cohesive care for patients. I am a native of Orange County, and so I grew up here and did a lot of different training all over the country, and finally was able to settle back here in 2017, where I've been in practice as a reproductive endocrinologist and infertility specialist. So I started my training as an OBGYN and then did 3 years of extra training as a fertility specialist. And um, like all providers, I think we all start somewhere, gain some experience out of our fellowship training, which is exactly what I did. And then starting in 2020, in the midst of the pandemic, I decided to open my own solo practice. Scary, but also I had a vision, and my vision was that I really wanted to have a very small boutique like concierge practice where I felt really connected to the patients. I wanted the patients to be able to walk in the door and know their nurse or coordinator, and also know that they were going to see me and have FaceTime with me at every single visit, from doing my own ultrasound scans for patients and then being able to sit in the office and talk to them afterwards. This is kind of the approach that I've taken. I'm a very people person, right? I love to chat with people. I love to form relationships and bonds. And I think that really helps in this process because no two people are the same. No two protocols or treatment plans are the same. And it's really when you get down to the conversations with different people where you can learn a little bit more about what their needs and desires are for fertility treatment, what avenues and routes we can take, how can we think outside the box. And so that's what I've kind of focused my practice on.
Well, what I love about your practice style, Dr. Kashani, is that everything is customized. And when I refer patients to you, I always tell patients how much I admire your protocols because it's, like you said, it's never the same for every patient. I mean, everyone's unique, and I can see the level of detail that you put into their protocols and how, things are just modified accordingly. And because as you know, IVF is a moving target and things constantly change, and our bodies constantly change as women too, and how we respond to procedures and medication protocols too. So I love that about your practice, and you've created such an amazing place for couples to come in and to feel really supported in their fertility journey. And I've referred a lot of patients that have unfortunately maybe had not such great experiences at other practices. And, they just love your practice and your style and how, every patient feels like they, are special, and
They honestly really are. They're going through their own unique journey, right? This is not an easy situation. Nobody signs up to have difficulty getting pregnant. Once you're in that situation, then you're trying to navigate so many overwhelming, treatment plans and options and which one's right for me. And so you really need to have somebody who you feel comfortable talking to and who knows that, at that moment, they really are so special. And this is the whole goal is
Sure.
to help build their families. So it's a truly a pleasure to be able to take care of people and let them trust me and have them let me be part of that journey. So and thank you for the referrals and thank you for also taking such diligent care of patients and coming up with great protocols for them with acupuncture and supplements and detoxes and diet and lifestyle modifications. I think it's not just one box approach. Here, take some injections, have your retrieval, it's going to pan out. It doesn't always happen that way. And so I think that more and more people are understanding that there's nuances to IVF and there's different little, tweaks that can be made and modifications and complementary things that can be done to get patients the best success.
Right. Well, it's my pleasure. And I do think that there's this level beyond physical for patients. It's like mind, body, spirit. And as you know, there's a lot of broken hearts through the process. And just, there's a lot of heartache in this fertility process. And I think being able to come into a place that just, nourishes you and just holds that space for you to let you discuss options and like maybe this cycle didn't work out and what can I do differently this time around, and I've already failed 3 cycles at another clinic and I need a fresh perspective. I'm sure you see a lot of that, Dr. Kashani. I know I certainly refer you patients like that, and
Yeah.
when they need a fresh set of eyes,
Yeah.
on their case. So
And it's hard because especially people have had unsuccessful cycles elsewhere. For anybody, you're so scared after that. There's the concern about the second cycle and the anxiety that then comes around that. And already, no matter what, you're going to be under stress. And then you want to make sure that you're in a situation where you can have some support and um, acknowledgement that it's so stressful and what can you do to decrease that stress in some way, whether that be acupuncture, exercise, meditation. These things are all complementary to help. And I feel like it's really hard for patients who, want to give up easily. And then thankfully, hopefully, my goal is to give them hope that it's okay, that it may not always happen. I've had patients of my own where it's not as successful the first time. We learn something really important and we tweak things, and the second cycle is drastically different. So it's hard not to walk away sometimes from fertility treatments, but some of the times it's just like you said, a fresh eyes on things or just a different approach in the conversation of like, well, we've really delved into this. Let's examine it. Let's see what we can do to improve for the future.
right, and I think that this part of practice is probably the hardest is when you're seeing patients that kind of are in that sort of that downswing of things where they're just they're in a discouraged place. I think when you get new patients, it's their first time. They've never seen a fertility specialist. It's a different experience, I'm sure, for you
Mhm.
as a provider too. And I have a couple questions for you, and these are questions that I get asked a lot by my patients.
Sure.
So, one of the questions that I get a lot for patients that are just starting their journey and maybe they're trying naturally for like the last year, when do you think is a good time for a patient to start care with a reproductive endocrinologist?
I think it's honestly patient dependent, because some people are very much the type that they want to have everything tested sooner just to have that information because they're like, knowledge is power. If I know earlier on, the better. And so they're right off the bat, like within 3 to 6 months, wanting to get a consult to do fertility testing, basic things like sperm analysis testing, checking their ovarian or egg reserve. So I think that for a lot of people, I think it's reasonable to definitely see somebody after 6 months of trying, especially if you're over the age of 35.
Mhm,
Or if, for example, you know that your family history, for example, your mother went through menopause early or had difficulty getting pregnant, this is another reason to seek provider consultation sooner. If you're, between the ages of, 25 to 35 or 25 to 33, and you've been trying for a year, but haven't really been trying, I think it's reasonable to wait one
mhm.
year. But I also tell every single patient, like, you know your body so well, you have an intuition. If you think your cycles are not that regular or something seems off with your periods, or your, partner said that maybe they had something going on with their, an infection in their testicles when they were younger, and you're
Mhm.
worried and you can't get that thought out of your head, there's no reason you have to wait a certain amount of time to seek consult for with a fertility specialist, because a lot of the testing is lab work and then a sperm analysis test, which isn't as, invasive, and it's pretty easy to do and get some answers sooner. Um, so I always encourage people that it's okay to be seen sooner if you want to.
I love that advice because I think it's one of those things where in the past, a lot of OBGYNs would say, well, just try a year first and let's see how you do. But like you said, knowledge is power, and patients come so well informed now.
Yeah.
Everybody is about data, right? So, they're like, I tried 3 months and I think that's time. I wanted to get all the testing. And I think it's great that they're open to testing. And
Yeah.
then you have other patients that are scared, and they're a little bit hesitant. It's
Mhm.
almost like they don't want to uncover things.
Yeah.
And so you have
They're like, "Well," yeah, exactly, or they're like, "I'll just try 6 more months," and
Yes, and in your mind, like, okay, they're 38, and so I'm, gently nudging them, like, well, let's just do a little bit of lab work. Let's just, and I think a lot of patients are scared of the HSG because they've heard things like it's painful or it's
yeah.
uncomfortable, and so I kind of see a full broad spectrum of patients in my practice. I have patients that are already coming in an IVF cycle, and then I have patients that are on the other extreme that are just starting and they are really more in the natural approach.
Yes.
And perhaps they're against doing more intervention, but at the same time, you kind of have this inkling like they may need a little extra help. So
Mhm.
I generally will kind of at least nudge them to get some testing done
Yeah.
to kind of get a baseline assessment of where they're at, especially if they're over 35.
For sure. And you're so experienced. I know you I'm sure have your intuition and know when to like help patients move forward with, okay, I think you need testing. I feel like you over the years have seen so much and are able to help hone in on what kind of things patients may need and help them kind of enter or start that process.
Thank you, Dr.
Because for
Kashani.
sure people are hesitant. I think that there are some, fertility doctors who get a bad rap. You walk into their door, they may be 27, and they're like, "Oh yeah, you need IVF," right? Like everything's just IVF, IVF. And so
Mhm,
they were like,
mhm.
"I don't want to step foot there. I don't want to do IVF."
That's
And you
right.
don't know that you have the options of talking about other things or just getting
Sure.
testing done. And maybe the testing identifies something simple like, the motility of the sperm is kind of low and there's supplements that men can take to improve motility or other lifestyle changes. And then all of a sudden, within 3 months, the sperm parameters are better. Well, had we not checked, maybe it would have stayed that way.
Right.
Um,
Absolutely. Yep.
it's hard because you don't want to be pushy and you don't want people to come in and worry that it's expensive or I'm going to have to do IVF. I think it's just a matter of finding the right provider who's open and willing to, first off, just start with testing and exploring,
Mm.
talking about the various options. As you said, options can just be optimizing natural fertility all the way to some mild interventions like ovulating multiple eggs, and then all the way to the other end of it, which is IVF. So,
Right. Right. And I think in my practice, when patients come in, a lot of times they equate reproductive endocrinology and infertility with IVF. I don't think they understand that there's other steps in between. And so that's where I think the fear factor comes in, where
for
it's like,
sure.
oh, wait, I'm not ready. I don't want to be referred yet. And I know your practice is very different, Dr. Kashani. So I'm always very comfortable referring patients to you, even for like a workup or what I see a lot of in my practice is recurrent pregnancy loss.
So,
And that unfortunately is a common thing I see. And they're getting pregnant naturally, but they're just not able to sustain a pregnancy. And, anywhere from early loss to unfortunately second trimester loss. So those tend to be patients that I will refer out for further testing.
for sure.
Um, so, would you be able to share with us a little bit about the recurrent pregnancy loss aspect of your practice and what are some of the things that you tend to see or tend to test or look at for those patients?
Absolutely. So, recurrent pregnancy loss is a whole different thing, and it's really hard because people can't even get excited about being pregnant because they've already miscarried 2 times, and so they're finally pregnant, but they can't even celebrate that positive pregnancy test because they're worried what's going to happen. Am I going to lose this pregnancy? Is it just a biochemical pregnancy? So I think that a very thorough history is really important. With every single patient, I like to get down to the nitty gritty of understanding about the pregnancy, how far along it came, ultrasound findings, was there any genetic testing done? Was this a very early loss after a week that keeps happening?
Mm.
Are they later losses? Any family history of this? These things are really important. Um, so first, that's what we do. But then there's categories or breakdowns of, why patients can have miscarriages. Often as OBGYNs and fertility doctors, we do come up with an assumption that most pregnancy losses are due to a chromosomal abnormality, meaning there might be, instead of 46 chromosomes, 47 chromosomes within that baby. And that is something called aneuploidy. And unfortunately, that can result in miscarriage. Uh, Although that's not the case for everyone. So we can't always assume that everyone's pregnancy loss or miscarriage is from a chromosomal issue. So what do we have to investigate? There are hormonal abnormalities or disruptances in the hormones that can contribute. Very commonly, a thyroid abnormality where the thyroid gland is not functioning as well may cause you to have miscarriages early on. So one of the important things you should check for is a TSH, and that's something that can easily be supplemented with a prescription medication for thyroid hormone. Other hormonal issues could be just dysfunctions within the hormone prolactin, can change your uterine lining and receptivity, causing miscarriages, some correlation with vitamin D deficiencies. Those are the most common kind of hormonal disruptions that can contribute. Other things that are important is to rule out any kind of autoimmune condition that causes blood clotting. So there's something out there called antiphospholipid syndrome. This can cause early miscarriages, but also even later pregnancy losses in the second trimester. So what needs to happen is a antibody test. Antibodies are basically usually formed in the body to fight off infections or viruses, but you can develop autoantibodies. And these autoantibodies basically alter the environment of the blood and cause it to clot more easily, and then can lead to miscarriages. So that's an easy blood test that can be done. And if for some reason it does come back that somebody carries these antibodies, there are nice treatments, easy treatments for it. So that helps. There's everything we do, we want to identify a problem and be able to have a solution for it. So that's one of the things that can be done. Anybody who has had a miscarriage should make sure that the inside of their uterus is like an empty room and it's clear of anything that could be causing a miscarriage. So, for example, you have this tiny little embryo. The embryo is the size of a grape in a football field. It's huge. It has so much room to find a cozy spot in the uterus to attach an implant. But some people within their uterus have little overgrowths of tissue called endometrial polyps, for example. If that embryo attaches to one of those sites, then the embryo might not get enough blood flow. That could impact the growth of the baby. That could cause a miscarriage early on or later. People have fibroids. People can also be born with abnormalities in the shape of their uterus. They could have like indentations at the top of the uterus, and then that can cause miscarriages. So you always want to check the uterine cavity and make sure it's normal. So that's part of the anatomic investigation. It's also important to make sure that the fallopian tubes look healthy and are okay, not filled with like any abnormal fluid that could like leak back into the uterus and risk causing a miscarriage. And that's an assessment you mentioned before called an HSG or hysterosalpingogram. And then the final thing that should be looked at is the chromosomal analysis for both of the parents. This is called a karyotype. This is basically an assessment to make sure that all of the 46 chromosomes that you have, 23 that you got from your mom and 23 from your dad, are all aligned in order, and there's no what are called translocations or inversions or interruptions in the makeup of those chromosomes. If there is, then that can be the reason for recurrent miscarriages. Because every time you try to combine the egg and sperm, unfortunately, maybe they're getting the wrong number of chromosomes. So there are treatments for that. Usually that does involve doing IVF to do specialized genetic testing if that were to be the case. But those are the kind of basic tests we do for recurrent pregnancy loss. A lot of times we don't find the reason, we don't find anything, but there's still other things that can be done as treatments. So women can be given progesterone, supplementation, aspirin, frequent monitoring, ultrasounds. There's something known as TLC care, which basically means seeing patients weekly early on in pregnancy and being able to kind of just monitor them closely and know that they have somebody by their side who's checking everything rather than waiting 8-9 weeks until you get an evaluation. So these things can be helpful. And then there's some more specialized testing for pregnancy loss. It's not necessarily considered standard of care by like our society recommendations, but there's other, thrombophilia testing, which looks for more blood clots, other antibody testing, immunology testing, testing of the uterus for infections like chronic endometriosis. So there's various other approaches that can be taken to look at causes of miscarriage. But it's kind of, again, you have to do it on a case by case basis for those circumstances and for those particular patients.
Well, thank you for that thorough explanation. I think that covers many areas. Out of curiosity, I know that the EMA analysis is something that's done a lot along with the ERA during an IVF cycle, but just curious because you mentioned the endometriosis for being connected to recurrent loss. Do patients ever do that test in a natural cycle?
Yeah, I've done it before. So people have come to like look at their, to see if they have chronic endometritis, especially if their history is more consistent with continuously having very early miscarriages.
Mhm.
Then a lot of times we will consider and suggest, let's make sure there's no infection in the uterus. And then in terms of other tests for the microbiome, usually if we're doing ALICE to check for chronic endometritis, we'll look at the microbiome. Otherwise, I don't really just do the EMA test to look at the microbiome on its own very often. I think it's otherwise just something that we would suggest taking vaginal probiotics for, which doesn't necessarily harm anything. Rather than putting someone through a biopsy, I rather just treat them with vaginal probiotics. But we do sometimes use it in natural cycles or in patients who have recurrent pregnancy loss, and we're trying to determine one of the causes.
And I know the other component that's often combined is the receptiva. DX. So in a situation where a patient's coming in for recurrent loss, would that also be part of the workup too, to rule
Yeah.
out
Yeah.
endometriosis?
It's again, it's not part of our standard of care, but if somebody has suspicion that they have, incredibly painful periods or pain during intercourse, pain with bowel movements and their periods, and we're suspecting endometriosis, I think it's warranted in both the recurrent pregnancy loss workup, but also sometimes for infertility. Sometimes
Mhm.
people want to know, well, why am I not getting pregnant naturally? Every test I've done has been normal. It's been categorized as unexplained infertility. I don't think it's really unexplained. I think that a lot of those cases end up being associated with endometriosis. And one of the ways you can diagnose it non-surgically is Receptiva DX, the biopsy of the uterine lining, which looks for this marker associated with inflammation that can be seen in women with endometriosis. It's not the gold standard, it's still not the actual test that's supposed to be done to confirm, endometriosis. That is only done through surgery, but it is the next best thing that we have available. And I think that it's really useful because then if we do identify endometriosis, then we're going to talk to those patients about, seeking services like acupuncture, reduce inflammation, taking certain supplements that are helpful for endometriosis, a low inflammatory diet. I mean, there's various things that can be done. So some people want that information and knowledge even before doing IVF.
Yeah, and I see that protocol a lot in IVF patients that have maybe failed a transfer. That seems to be a common practice to incorporate the Receptiva, the
Yeah,
Emma, and the Alice. And boy, it's been so effective. I feel like a lot of the patients that we've been seeing together, that has been a really powerful
for
addition
sure.
to their protocol. And I'm just curious because I've been seeing a lot of patients that have had the Receptiva come back, and I know that the option would be, to be on Lupron for a couple months or surgery. And I'm just curious to know, like, when do you suggest which treatment protocol? And, and I know some patients don't want to go through surgery. It seems like majority of the patients would rather treat with medication than go through surgery. But I'm just curious from your perspective, what you've seen and what your thoughts are and your recommendations for patients.
Absolutely. So great question. It comes up all the time in practice as well. Like, what do I do?
Mm,
Um, the patients that I tend to advise to go the more surgical route are patients who really are symptomatic from likely endometriosis, meaning they have been having horribly painful periods for years and just have learned to live with it. Or they really do have some pelvic floor dysfunction or pain during intercourse. These are people that may really benefit from the surgery for their own quality of life, right? Like all of a sudden they're like, wow, I actually feel better now that my surgery has been done and endo has been removed. I can't even believe I lived that way. Those
mhm.
are the patients I think benefit. If there's any suspicion that there's tubal malfunction or an issue with the fallopian tubes, again, that might be a reason to do surgery. If there's cysts in the ovaries that look like an endometriosis cyst, that might be the better option for surgery. But all in all, we tend to not necessarily recommend surgery for everyone, only because every surgery has its own risks. I mean, thankfully, most endometriosis surgeries are via laparoscopy, which means it's minimally invasive with very small incisions, but they are still done in an operating room with general anesthesia, and that has its own risks. And so, if you can try to do a medical management, I think that it overall is easier to do. And usually, it's got some pretty bad rep, Lupron does, in terms of side effects. I mean, you're essentially going into premature menopause in a temporary course of 2 months, but nevertheless, it's temporary, and most people can power through 2 months of that treatment rather than again getting into a consult with a surgeon, getting on the books for surgery, recovery after surgery, and then the possible risks that can come with surgery.
What's the recovery time usually between? So if a patient already has gone through a retrieval cycle and they decided to do the Receptiva and it came back positive and they opted for the surgery, how long do they normally have to wait before they can transfer?
So usually we want them to wait about 6 weeks post surgery for their transfer. 6 to 8 weeks is ideal, but we don't want to wait too long after because then you worry that the endometriosis could come back. It doesn't come back usually that quickly, but ideally within the 3 months after surgery.
That makes sense. And actually, that's not 6 to 8 weeks isn't that long. I would have thought the
Um,
recovery time actually would have been longer. But I know it's hard to know that sweet spot of timing.
sure.
But, if you're doing Lupron, usually it's 2 to 3 months.
Right.
So I feel like having surgery, if necessary, it doesn't actually prolong it that much
No,
more.
not necessarily, no.
Yeah,
And I also just make note, like I really, if I do recommend the surgery route, I really want patients to be seen by someone who does endometriosis surgery regularly.
mhm,
And I say that because the whole point of it is to excise or cut out and remove any endometriosis, whether the lesion is big or small. And so you want somebody who does this so frequently that they're looking under every corner and every little nook and cranny, I would describe it as, to make sure that even a small millimeter lesion is removed, because that, if it's not removed or it's not a complete surgery, you can imagine the endometriosis may still, end up releasing these inflammatory substances, and then it defeats the purpose of treating endometriosis prior to the transfer.
right.
So I highly recommend that patients be seen by someone who does these surgeries regularly.
That makes total sense. Is there ever a time when a patient does both protocols?
Yeah, there actually is. I have a patient right now who's doing something similar. Um, there are some people who have endometriosis and also adenomyosis. Adenomyosis is basically the infiltration of basically endometriosis in the muscle of the uterus. And it's not something that's so easily treated because you can't really go in and take out the muscle of the uterus. It won't function anymore. It's basically destroying that. So what you could do is surgery for endometriosis and then follow up with Lupron therapy, because the Lupron is also supposed to help shrink the endometriosis that may be, for example, missed during surgery, not accessible, but also if it's in the uterus and the muscle of the uterus and that couldn't be removed, you can shrink that down with Lupron. So some people will do that double approach. Not very common, because
Mhm.
definitely people don't want to even do one or the other. But it does, there are some people that benefit from both.
Well, bless your patient's heart for going through that.
I know.
That's a lot. Yeah,
Hopefully she has success with our upcoming transfer. We shall see.
absolutely. So as far as conditions that you see in your practice, I know diminished ovarian reserve is something that you and I commonly treat together. Uh,
Mhm.
one thing that I've noticed that I've seen a lot of recently is hypothalamic amenorrhea. So I was just curious what your approach would be for treating HA, and if you
Yeah.
see a lot of that in your practice.
Yeah, it's interesting because it can be very much confused and people misdiagnose this as PCOS. Basically, both of the conditions, both polycystic ovary syndrome and hypothalamic amenorrhea, start with this problem with your menstrual cycles. That's the first thing that you notice is an irregular menstrual cycle, or all of a sudden it goes away, and they're from two different kind of reasons. But with hypothalamic amenorrhea, it's basically you do not, I always talk about FSH is this hormone that comes from the brain. It stands for follicle stimulating hormone. And within the ovary, the eggs all live in these follicles, right? So basically the brain doesn't make enough food that doesn't allow these follicles or eggs to grow. And so you have to do a workup to identify reasons that can be contributing to the lack of FSH production. Sometimes this could be something within the brain, and it's required to get an MRI of the brain, make sure nothing's putting pressure on that site. The pituitary gland that's not allowing production of this hormone, or so those are the things that we look at, other hormonal abnormalities. But sometimes it's related to really extremes of stress or extreme weight loss, anorexia, but it doesn't even have to be anorexia. So a lot of people are having amenorrhea or hypothalamic amenorrhea because they are really fit and they're
Mhm.
so focused on having such a low body fat percentage. I'm talking about percentages less than like 15%. And what happens is everybody's set point in their body fat percentage is different. And you may not necessarily have a very low BMI, right? You might have a BMI of like 18, 19, 20, not being underweight, but so much of your body is just muscle and no fat. And that fat is really required for the production of normal female hormones and ovulation. And so this is one of the what can come up that can cause women to have difficulty having regular menstrual cycles. In those circumstances, the first and foremost thing I do is talk to patients, as hard as it is, to actually stop or reduce their exercise, their extreme exercise, and start incorporating really healthy fats into their diet, which is hard for people to do. But I'm not talking about eating fast food. I'm not talking about eating fried food. I'm talking about having like good, wholesome, for example, avocados or nuts where you're getting healthy fats, olive oil, some types of fish, and really seeing if you can gain a little bit of that body fat percentage back. Sometimes a few percentage of body fat when it goes back up, or 5 pounds, that actually can resume menstrual cycles. If not, then that's the cases where we do help and assist by giving patients a little bit of low dose FSH, which stands for follicle stimulating hormone, the hormone supposed to be made from the brain. We can give it to patients in the form of injections to help kind of jumpstart and get them to ovulate again. So, but we usually like to start with the approach of a little bit of weight gain.
Mhm. I think that's a common thing that we see in Orange County because women are so active, being in sunny Southern California, there's a lot of runners,
Sure.
cyclists, and everyone is just in such great shape. So I'm sure you see this too.
Different than in other parts of the country for sure. But yeah, no, it definitely is something we see here. And with
Mhm.
the trend of all these fitness trends of different types of, Orange Theory and CrossFit and, various
Mhm.
types of workout classes. I mean, people are really thankfully invested in their health, but there are extremes that you can go to. And it's important to, this is why I always say, pay attention to your menstrual cycle and be on top of it. It's really a vital sign. It tells you a lot about your hormones. And if you think that they have changed, your cycles have changed, do not delay. You should seek consult, get your hormones checked to see what's going on.
I love that. It's a vital sign. It,
It is. It
the
really is.
health of your period or your
Yeah,
cycle. Definitely.
for sure.
I always tell patients it's there's yin exercise and there's yang exercise. And I think, in Southern California, we're really into the yang exercising, which is all the hit exercises, the spinning, the running, the high impact. The yin exercises would be more like yoga, walking, tai chi. It's still movement, but it's just
Yeah,
as vigorous and high intensity.
for sure.
So I kind of have that conversation of balancing yin and yang and doing a little bit of both. And patients kind of, have a sad face when I say that, but I'm like, it's okay. I promise it's still gonna relieve
It's
stress.
still going to be
Because
good.
it's
Yeah.
really, it's
Okay.
an outlet for stress for most
I
patients, right?
know.
So then they're really into I need to spin 4 days a week, or I need to, run 10 miles, 10 to 15 miles 6 days a week. I'm training for a half marathon or, so, and I admire patients that are so fit and devoted to their exercise routine. But I think that's probably the biggest challenge, like you said, is getting them to kind of scale it back a little bit.
Mhm. Absolutely.
And I always tell patients it's temporary. It's just right now. It's just going to help you to get to the state where your body's in homeostasis to be able to produce the hormones you need to become a mom, to get
For sure.
pregnant.
For sure.
But I'm glad that you have a similar conversation with your patients.
Yeah.
One thing that I do see a lot of with amenorrhea, and I'm sure you come across this too, is birth control. So
Mhm.
amenorrhea after long-term use of birth control. So
Sure.
just curious, is that something that is pretty common in your practice?
It's actually not common. I think that we just hear about it because, of course, a lot of women come off birth control and their periods come back regularly. They don't go home and write about it, or they don't like bring it up, right? I stopped the pills and my periods came regular. But definitely, there are some people where they've been on pills for a long time. And it does take them a couple of months to just get their brain to make the hormone FSH again, follicle stimulating hormone, in the nice, like normal fashion so that you can ovulate, release an egg, and get pregnant. It's also another possibility is that women have developed over the course of years their own hormonal issue, whether that's undiagnosed PCOS, polycystic ovary syndrome. And being on the pills has kind of masked that
Right.
problem and made it seem like everything was normal. And because every month you take these hormones, you get a withdrawal bleed, you get your period, and it's very regular and set. Once they come off the pills, that's not happening because they actually had PCOS and it just never was diagnosed before they went on the pills. So then it's being uncovered as, oh, this hormonal issue. It's really not the cause from the birth control. It's really more so that maybe it was masking the symptoms, and so it wasn't identified or diagnosed earlier on. Same thing that can go is that there are some people who are on birth control for years and years, like I'm talking about from their 20s till 39 years old. Okay.
Mhm.
They come off the pill because they're finally, going to start to try to get pregnant. And then all of a sudden, unfortunately, they identify that they're not getting their periods regularly. And then they go in and get some testing and workup done and find out that they have really severe diminished ovarian reserve, or could even be already menopausal or premenopausal. They would have not known that because that their cycles had started to get irregular because
Right.
or their egg quantity had gone down in their mid 30s because they were on pills the whole time. So that is one of the things that does come up sometimes in practice is like, oh my gosh, did the pills cause me to go into, early premature menopause? Probably not. It was just that it wasn't really identified earlier by a change in your menstrual cycle. And so now we're finding out way after the fact.
That makes a lot of sense. And I do see that the PCOS uncovered situation a lot too in my practice, especially if they've been on birth control for 10 years plus. In terms of the patients with PCOS, what type of treatment plan is usually best for those patients in terms
Yeah.
of,
Okay.
and there's PCOS, there's that spectrum, right?
Sure.
You have patients that have just,
The classic type, which,
yeah,
yeah.
it's with testosterone, with androgen elevation, and then you have some that also have the component of insulin resistance too, and prediabetes.
Yes.
So, yeah, I'm just curious for you, what do you see and what's the common treatment in your practice for those patients?
Yeah, so I think that most patients with PCOS are the more classic type where they have elevated testosterone, tend to be, unfortunately, overweight. And so one of the biggest approaches first talking about some lifestyle modifications. And this is helpful whether you're going to be doing fertility treatment, just taking pills like Clomid or Letrozole, or even IVF. So it's important to try to get into a regimen of exercise and diet to lose at least, again, 5 to 10% of body weight can really help regulate cycles, improve egg quality. So this can be through at least 3 times a week of exercise for 30 minutes. In terms of diet, definitely a lower carbohydrate diet with less sugar is always going to be a benefit. In patients with PCOS, we should always do some additional glucose testing or testing for insulin resistance. So there's not the test that's really commonly standardly done to test for insulin resistance has to be in a hospital setting. It's not very useful to do. But what we typically do is we look at a fasting glucose, fasting insulin, and also hemoglobin A1C. That's an assessment of your glucose or sugar over the last 3 months. These are the three easier tests to do and can give us an idea and picture about where their status is. If a fasting glucose is high or fasting insulin is high, this is when medications like metformin can help women with PCOS. It reduces their insulin levels, their sugar levels, they're not holding on to fat as much, they lose weight, and then this in itself can be helpful for the regulation of their female reproductive hormones. Alternatively, you can do a 2-hour glucose tolerance test. This is actually advised by the American College of OBGYN for women with PCOS. And that basically is where a woman will drink a 75-gram sugar load and then 2 hours later check their blood sugars to see if they can tolerate that sugar load. And if they're elevated, they have an elevated blood sugar. And if they do, then they meet criteria for probably insulin resistance and do need to end up taking medications, whether that be metformin or other insulin sensitizing medications.
I
Uh,
love all of the lifestyle recommendations that you
yes.
give patients, the diet and lifestyle
Yeah.
tips, key, especially.
Another supplement before I forget is myo-inositol or inositol. That's definitely great for metabolism, especially in women with PCOS. It can also help with egg quality. So that's something we usually will recommend too.
Nice. I love how we're like alignment with the diet and
Yeah.
lifestyle and supplements.
Yes.
Well, thank
So
you so much,
important.
Dr. Kashani, for answering all those questions. These are all the things that I just kind of pull all the questions that I've received
Sure,
and
you get a
asked
whole
for.
bunch all the time, never
I,
ending. But
I do. And one of the things too that I wanted to ask was, this one comes up a lot, and I know we have co-treated several patients with this, but um, diminished ovarian reserve patients, patients that, whether it's premature ovarian, diminished ovarian reserve, or just diminished ovarian reserve in general. Just curious if there's anything that you recommend for those patients, whether in the natural medicine world or even with like some of the latest technology that's out there, like PRP and some of the
yeah.
other cool things that have come out recently for ovarian rejuvenation.
Yes, great question. So, first off, I think that I always try to talk to patients about the fact that diminished ovarian reserve represents egg quantity, okay, being lower. And some women get diagnosed with this at a younger age, in their early 30s. And what's important that they know is that quality of the eggs is more important and more linked to age than quantity. So you could be somebody who's has a really low AMH of zero point 0.2, okay, but be 31, you still have a great chance of success, whether naturally or through fertility treatments, compared to someone who is 41 with an AMH of like 2 or 3. That's how much egg quality matters and is linked to age. So it's really hard not to get weighed down on this diminished ovarian reserve diagnosis, but it's important to look at it based on age. So I always first off talk about that. Secondly, there are definitely things that can be done to improve egg quality. Sometimes things that can help even with increasing follicle counts or kind of helping with women with diminished ovarian reserve. So what I typically suggest is taking an antioxidant like coenzyme Q10, various doses of either, if it's the active form of ubiquinol, 400 milligrams to 600 milligrams a day. And then oftentimes I will check an androgen, which is called DHEA. And if the DHEAS levels in the blood are low, okay, it's telling me the ovary is kind of suppressed, not making as much. And these are the patients with diminished ovarian reserve that would benefit taking a DHEA supplement. I don't like to just give it without checking levels because some people really don't need it. Their levels are really truly adequate. But there are some people who are really low, and then we can titrate the dose of 25 milligrams or 50 milligrams or even 75 milligrams based on their blood levels. Okay, so that's something that can be done and might help. I always recommend acupuncture because I think it's great for many, many reasons. And other things that can be done to reduce stress, such as meditation, yoga, these are also beneficial. Exercise to increase blood flow to the ovaries. There are other alternative treatments out there, such as ovarian PRP, which is platelet rich plasma. Basically, there are providers out there who can take your platelet rich plasma. And just like doing an egg retrieval, you're kind of doing the reverse. You're basically putting the needle into the ovary and injecting or instilling this PRP with likely growth factors, stem cells, other things that can rejuvenate or wake up the ovaries. And sometimes we see more of a response after doing IVF or treatments because this PRP was helpful. In my practice, the people who've done this, the results are variable. There's some improvement, but I wouldn't say that it's so significant that I recommend a lot of people do this. But definitely, if somebody wants to try it, it's available and something to consider. And then there's new talk out there of an additional medication or treatment option, which basically is called rapamycin. And there's a couple of providers that are looking into this. It's kind of up and coming in the research, but this might be a link to helping postpone menopause or helping women maybe get some more follicles. Again, it's so new and under investigation at a lot of like research centers and for other benefits, but something that some providers are using. I haven't done it just yet, but it's in the works for it to basically come and see if that might be helpful.
Well, I can't wait to hear and learn more about this medication. I
Yeah.
know the other medication that I see used quite a bit is Omnitrope
Yes.
or HGH, and not for necessarily diminished ovarian reserve, but more for equality support.
Yes.
Is that something that is common in your practice, and have you seen success?
Sure. So omnitrope or human growth hormone can be used actually to help women with diminished reserve to help them increase follicle counts. It's done as priming prior to IVF. And I don't really use that because I haven't seen much of a benefit in my patients, but I do use it in our stim protocols. I use it either at the beginning of the stimulation cycle or halfway through. And the thoughts is that in some women, it does help the chromosomes line more evenly. The maturation tends to be more normal at the time of meiosis. And so sometimes we'll use this in egg retrieval cycles in women who are over 40 or other patients who have undergone IVF before and didn't get as many genetically normal embryos. And we're trying to hopefully change that with the subsequent cycle.
Well, and I've seen it used too, not that often, but once in a while I'll see patients using Omnitrope and natural fertility too.
Yeah.
And I'm sure it's not as common in your practice either, but that's something that I've seen patients kind of look into as well. And maybe they'll be on it for a couple cycles before, not necessarily preconception care, but they're kind of like starting to try, but then they're using Omnitrope in sort of that like preconception window. So I'm just curious to what your thoughts are on that and if that's beneficial or not, in your opinion, for natural fertility.
Honestly, I don't think we have enough information or data to say one way or another. I don't necessarily think that it would be harmful with the low doses that people are
Yeah,
using, really, really low dose, but I definitely wouldn't suggest that it be a mainstream option that people do.
right.
And there's probably a lot of costs with it that doesn't provide that much of a higher success, at least not that we know of right now.
Mhm. Well, I am excited to see what the data shows in the upcoming years
Sure.
for
It's
all the
always
new.
changing. It's everything's updating. It's such a everly evolving field. It's constantly something new every couple of years. So
Yeah, and it's exciting. It kind of keeps you on your toes as a
for
practitioner.
sure. For
Okay, I
sure.
have one more question for you,
Yes,
Dr. Kashani. Thank you so much for all your time.
yes.
This question is kind of more for natural practitioners and primarily more acupuncturists and Chinese medicine providers. What is your take on Chinese herbal medicine and the integration of herbal? I'm totally putting you on the spot, by the way. Chinese herbal medicine with fertility protocols.
Sure. So I'm totally on board with incorporating everything. For patients, I will have them kind of as they're doing acupuncture for prep for IVF for a couple of months. I think it's fine to do the supplements. I do tell all patients, I'm like, we just don't have a lot of data from our end, from the literature side, but definitely it's not like these are made up protocols or medications or supplements. That definitely has been studied and found to be beneficial in different studies and literature. So I am okay with patients using them up until the egg retrieval, but then once they start stimulation, just because we haven't looked at the interactions between every single herb and supplement, I tend to ask patients to stop at that point.
And that is how we practice in
Yeah.
our clinic, and that's usually what I suggest for patients too, because the herbs are estrogenic and progesterogenic, and IVF is such a controlled environment, we don't want to interfere with that
Sure.
process at all. So, usually when patients are on a break, that's usually when we'll prescribe, or if they're just coming for preconception care, then we'll treat.
Yeah.
So we are totally in agreement there. Just to let you know, I don't usually keep patients on
No, I know you
Chinese
don't.
water
It
or
works out perfectly that way as well, too. So,
well, thank you for commenting on that. That's always something that comes up a lot with
yes.
my patients is, so can I continue the herbs during my retrieval cycle? And I usually say, I at this point the REI is taking the lead. And usually they want to be able to, you know, to control the medication cycle, and we don't want anything to interfere with that and your
Yeah.
life. So, and most patients are fine with that. But I think if they've been seeing us for a while, they've been on herbs for quite some time. So I
Hard to
think,
come off of it.
yeah, exactly. They're having a little bit of an emotional withdrawal
Oh.
because it's something that they've been used to taking. So, is there anything else that you would like to share with us? Any advice that you have for couples that are on their fertility journey or their journey to becoming parents?
I think that it's always good to just explore different avenues and routes from like Eastern medicine, to Western medicine, complementary medicine, and finding kind of like an option that fits best for you and what you want to do, whether that be more the natural route. Or a treatment route where you're still able to kind of incorporate a cohesive team approach. I think it will help, and having someone that can always support you through the process is going to be great. You should find support groups, or be comfortable with a provider that you can talk to and ask your questions, because the last thing that you want is to not have something that works out successfully and you feel like you didn't get to do everything in full, whether that be taking supplements or asking the right questions or tweaking a protocol. It's just doing something different. So I just advise everyone to speak up, get support, ask questions, find resources. It's an important time, and it's also a limited time where we have a reproductive window. You don't want to delay too long necessarily, but at the same time, you don't want to rush into anything and do something overnight and then not and look back and be like, oh my gosh, I wasn't prepared. I didn't prepare my body for the treatment. So these are just finding a happy medium between that.
I love that advice.
Thank
And
you.
the fertility support group that you're involved with, I know that
Yeah.
you and I are that we are connected through this group, Infertility Unfiltered. Dr.
Yeah.
Kashani speaks in that series. For both series or
Just
just
primary for infertility right now, but or secondary infertility, I think, or both. I don't know. I think
I
back
think
and forth.
we're on the primary infertility together.
Primary, okay. So yes, I used to do secondary, that's why. But Infertility Unfiltered is a support group that used to be available only locally where they would meet. Thankfully, with COVID and the use of Zoom, we're able to extend it out across the country. And it's such a great support group. You meet a good group of women that becomes like your cohort. You can bounce any ideas, thoughts, or questions with them. You get to meet a whole slew of different types of support networks, from meeting providers to mental health specialists, learning about acupuncture and various things. So it's so highly recommended. And there are also other support groups available through resolve.org as well. And they have local meeting groups, online groups, and just so many different places where you can find people going through similar journeys as you. And that could be a journey of using, third party reproduction, egg donation, sperm, a male factor, and you just like don't know what to do, or, also just finding other people who are trying to optimize natural fertility. So highly recommend looking into those resources if you haven't already.
Thank you for that information. And thank you, Dr. Kashani, for dedicating this time to this podcast.
Yeah.
And I
Thank
am
you so
so
much for
excited
having me.
about your practice and the development of your practice. And I can't thank you enough for your education and your wisdom. And you are one of the best teachers that I can ask for.
Thank
I've learned so much from you over the years.
you.
So,
Same thing with you, likewise. And I just continue to look forward to helping care for patients and couples together with you over the course of the year. So
you.
thank you so much for having me. I always love talking to you and seeing your face, and hope to see you soon over here with some
Okay,
transfers.
Dr. Kashani, thank you again. I
Take
really
care. Bye bye.
appreciate your time. Okay, take care. Bye.